Hello, everyone, and welcome to Just Medicine. My name is Gina, and I am currently a medical student at the University of British Columbia. I will be hosting a two-part series with different guest speakers on the complex intersection of medical assistance in dying and mental health. Medical assistance in dying, or in short form, MAiD, first became legal in Canada in 2016. The total number of medically assisted deaths by 2022 were reported to be near 45,000 people. It is expected that on March 14, 2024, MAiD will be eligible for people solely suffering from a mental illness. This law can provide autonomy for those who may be vulnerable and suffering immense physical or psychological distress, but it has also raised a few concerns. In today's episode, we will be chatting with Dr. Diane McIntosh about the equity and socioeconomic concerns surrounding MAiD and exploring the profound implications it holds for individuals struggling with mental health challenges. Dr. Diane McIntosh is a psychiatrist and a clinical assistant professor at UBC with a particular interest in mood, anxiety disorders, and ADHD. Dr. McIntosh has authored numerous books and has established multiple advocacy programs on mental health issues. Enjoy the episode.
You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello, everyone, and welcome to Just Medicine. My name is Gina, and today we have a very special guest with us, Dr. Diane McIntosh. Dr. McIntosh is a psychiatrist, an educator, and a mental health advocate in Vancouver, BC. So hi, Dr. McIntosh, welcome. It's so great to have you here.
Oh, I feel really honored to be here. Thank you for asking.
Of course. Before we dive in, I'll let you introduce yourself a little bit. Could you tell us a little bit about who you are, your background and training, and what drew you to the field of psychiatry?
Sure. So I actually did all my training in Nova Scotia at Dalhousie. Before I went to medical school, I was a pharmacist and then applied and went right into medical school, which was extremely helpful as a background for my experience. I loved everything in medical school. I think I could have been just about anything. I did a couple of years of a pediatric residency and found out that that wasn't where my heart was. And so I did adult psychiatry, and I really felt I made the best decision for me. I started my career actually in a chronic care unit treating individuals who had very severe and persistent schizophrenia with a criminal justice background. And then I worked at the first operational stress injury clinic within the Canadian military. I was a civilian working at an OSI clinic at CFB Halifax. Then into private practice, did some clinical research over several years, moved to British Columbia, and I've been in practice for now 25 years as a psychiatrist. A big part of what I do is focused on trying to support our family practice colleagues, nurse practitioners, to be more confident, rational prescribers in psychiatry because we lack objective measures. So there's no X-ray or lab test that I can say, oh, you have bipolar 7 and you need this drug. We don't have that objectivity that other specialists and areas of specialty have, which I think has been one of the reasons that psychiatry has been generally looked down upon as a specialty. And also the stigma continues, and it doesn't live, the stigma about mental illness doesn't just live there in the community, it lives in medicine. And that's why any opportunity I have to shed some light on the science underlying the psychiatric disorders and concerns I have about patients who are living with psychiatric disorders, I really relish the opportunity. So thank you.
Wow, thank you so much for sharing that. It's really fascinating to hear about your journey, and it seems like you've had quite a career trajectory, which is incredible to hear. Having these discussions today about the nuances of MAiD and mental health, I think your expertise will come in very valuable to us. Now, with that, I wanted us to jump right in. And to set the stage, I was wondering if you could provide a very brief overview of what the MAiD laws in Canada currently are and what we expect to change by March 2024, just for our listeners who might not be familiar.
Sure. So, and certainly this is not my area of expertise, and there are others who could speak, I think, with greater clarity around what exists now. I did not expect that we would be in a situation where we were offering access to MAiD for people who have psychiatric disorders. So to be eligible for medical assistance in dying, you've had to have met all the criteria of living in Canada, being 18 years or older, having a grievous or irremediable medical condition. Your request to die had to be voluntary. So you couldn't be, under undue influence of your evil child who wished to take all of your money or something like that, and that you were able to give informed consent. And so there was really that critical piece of grievous and irremediable. And they have clear criteria around that. What does that mean? Is that you have a serious illness or disease or disability. It's an advanced state. It's not going to get better, can't be reversed. And your experience is unbearable, whether it's related to your physical suffering, your mental suffering, and that there's nothing that you can do to reverse that situation. So that's where we were. And until recently, well, it continues to be the case. If you had just as a primary psychiatric disorder, you were unable to access MAiD. But then there was a bill C7. There was a panel that was convened, and it made a recommendation. I think it was in 2022 that medical assistance in dying be extended to people who are living with a mental illness. In June of 2022, they had a joint committee that gave an interim report saying that this should be covered, that someone who had a mental illness could be the sole determiner, as the sole underlying condition. And then in early 2023, it was actually the bill was tabled, and in March got royal assent. But then there was a hold put on that until March of this year, I think March 17th, 2024, at which time medical assistance in dying is for someone who has just a psychiatric disorder should be able to access that option. They do make a differentiation between a psychiatric disorder and a neurocognitive condition, which kind of surprised me because of the fact that they differentiate these two, saying that this is solely for a mental disorder such as a psychiatric disorder, depression, for instance, and personality disorders they add in there, which I'd like to talk to you about too. But it says it doesn't include neurocognitive or neurodevelopmental disorders. And yet it kind of misses the point that when people have a serious psychiatric disorder, they also have very significant cognitive impairment.
Something that stands out to me is when you have a neurocognitive impairment that might impact your competency to perhaps want to seek MAiD. But thank you so much for that super helpful but brief overview of the current MAiD laws, and then the kind of the evolution of what's happened so far and the upcoming reforms in the next few months. And it's very clear that these changes are going to have significant implications. But shifting our focus, I was wondering how you see the current MAiD legislation in Canada, and if you could touch a little bit on what impact it's had on the medical profession and also patient lives so far.
So I am someone who comfortably says that I believe that there is a value to having access to medical assistance in dying. So I am not an anti-MAiD person, but I am extremely concerned with how much this is happening in Canada. Many people who are listening have probably seen the statistics that at the same time that Canada had medical assistance in dying legislation, so did California. They have approximately the same size population. And I think in 2022, and please don't quote me, I may get this wrong as it's truly off the top of my head. I think in 2022 in California, they had something like 400, 500 cases, and we had 11,000. So we are killing a whole lot of people. And maybe all of that is absolutely appropriate, but my greatest concern, and this is what extends as well into psychiatry, is we don't have access to care. we don't have access to family practitioners. In British Columbia, there are more than 1 million unattached patients. So you can imagine that's having an impact on cancer care, right? We know that people are not getting their usual screening, making sure someone has their vaccines to prevent cervical cancer, which is completely preventable now. So then they end up with cervical cancer, then they can't get the care and so on. They're not having their breast screening, they're not having their prostate screenings. So then we end up with advanced disease because of the failure in our system. And psychiatry is one of the areas where we have the greatest challenges with a lack of access and that objectivity that I mentioned at the beginning. We don't have good objective measures, and the best that we have, which are our clinical scales, are very poorly utilized.
I think it's evident that kind of the evolution of MAiD is really shaping our medical field in many ways. And you mentioned access to care. According to few statistics I think it's from the Center of Addiction and Mental Health, only 1 out of 3 Canadians have access to mental health care who need it, and only 1 out of 5 children. And so, as you mentioned, a lot of times patients may be seeking MAiD mainly due to the absence of these social supports and the care that they deserve instead of their medical condition.
You bring up an important point, and actually I didn't fully answer your whole question, because you said, or you asked, what is the impact of that on our colleagues, on physicians, nurse practitioners, and also on others, the person themselves or their family. And I don't think we have had enough of that conversation about what is the impact on our colleagues, for instance. And I have a number of family practitioner colleagues who have had patients who have died through medical assistance and dying, that felt absolutely devastated by the process, that it felt like this was not in their hands to be able to adequately support the individual. Perhaps they didn't have access to really high quality palliative care, access to treatment early enough. So I think that we're not thinking enough about, we already have a very burned out group of healthcare providers across this country in every area of healthcare. And this is an emotional burden for the providers, but also for the patients being in pain, for the fact that we're not addressing their suffering. And so that they're at that point where they may not have decided, but had they had access to appropriate care early on, and or at this time when they're in agonizing pain and everyone's terrified to treat pain. And so they're pushed to this point. And also families. And, there are some heart-wrenching impacts, absolutely, of suicide. And so one of the hopes was that perhaps by offering medical assistance to dying, people would not choose suicide. They would have their family around them as they've made that choice. That is not always the case. So sometimes there's a great disagreement within families around whether or not that person has had adequate care. Their family members are not part of the decision-making process unless the individual decides to include them. So I don't think that we've thought about the unintended consequences of taking this approach and how it affects everybody within the circle of care, including people's loved ones, their supporters, and the individual themselves.
Yeah, those are all very important points I think that you raise here, and it kind of shows the complexity of this issue. And I really like how you mentioned how a lot of times the people who are administering MAiD, whether it's a nurse practitioner or a physician, they also feel devastated and that emotional burden of the situation too. And it's really valuable for us to hear your personal experience based off of your colleagues, and also to hear what you know about patient experiences, because at the end of the day, this isn't just about policies and reforms. It's about real individuals, their stories, and a decision that's going to greatly shape their journey. So it really just reminds us of the human impact that lies at the heart of these discussions.
Because it seems, and certainly this has been my experience that I've heard from colleagues, but again, secondhand, not my direct experience, that the people who are actually administering MAiD are very pro MAiD. And so these are my family practice colleagues. Their patients have made this choice, and then their patient is in a completely different system. And in some cases, they're not even included in the discussion. So I have my experience, what I've heard from others is that the people who are doing the administration are pro-MAiD and very supportive of the process. I may be wrong about that, but that the clinicians who are left behind, who are not part of the discussion, who have that relationship with the patient, are the ones who feel like the system has let their patient down from access to care, and that they were not included in the process or even, spoken to within the whole process. The process just sort of off it goes without you once the patient makes the decision.
And you mentioned access to care and clinicians or physicians feeling as though they're not able to fully support patients in the way that they need to. I'm wondering what are some of the equity and diversity and inclusion issues that you think may arise with MAiD for mental health?
Well, we have a problem with access across the board, and you just gave those numbers: 1 in 3 adults, 1 in 5 children. Just imagine that. Most mental illnesses start in childhood, in the teen years, and yet there's 2-year waits to get access to a psychiatrist. So we have access care just in the general population. And then when you think about more vulnerable populations or populations that have been marginalized, they have even more access issues. So just opening the door up to a group of individuals who really need to have a psychiatric assessment and careful management, especially with a disorder that has no objective measures, to me, it's just wrong. And we think about people who have disabilities who we now know are making a choice for MAiD because they can't get a chair that appropriately meets their needs, that they can't get the supports they need in the community, so they choose not to live anymore because we have let them down as a society as to helping to support them through their disability. This to me is, as we're judged as a society by how we treat our most vulnerable members. We saw that actually through COVID with what happened within seniors' homes across the country. It was just heart-wrenching that people were essentially left to die in those for-profit care centers, care homes. It just speaks to how the people who are most vulnerable in our population are getting the worst kind of care, and that is particularly the case for psychiatric illnesses.
You mentioned marginalized people having even poorer access to care, and situations such as being on a wait list for treatment, being refused disability benefits. These are all socioeconomic reasons that could primarily, if not completely, drive a person to seek MAiD, and even perhaps worsen an individual's medical or mental health condition. I'm curious to ask if there's any way that we can address these barriers to access and make sure that individuals are receiving the care that they need before they resort to MAiD.
Well, I have my own beliefs of what I'm spending my time doing now is trying to create a technology that supports family doctors, nurse practitioners, psychiatrists, even at the point of care, to have the most objective overview of a patient. It's called RAPIDS, my technology, but there are other technologies there. There are other ways of improving access to care by having more nurse practitioners, by training allied health professionals to be able to do the screenings that are necessary, to use more virtual care. When I started doing virtual care, which was well before the pandemic, my fear came from, how would my patients experience it? And to a person, they have loved it because, to me, it democratizes medicine, right? It meets people where they are. I've seen policemen in their squad cars. I've seen people in Starbucks. They don't have to drive to me, put money in the meter, have to leave work and with an explanation of why they're seeing their psychiatrist, who are they seeing and why do they see their doctor so often. So it was natural. It was a natural progression and it fits very well with psychiatry, but it's physicians who are very slow to I think feel comfortable with new technologies. To me, it's a real opportunity for us to improve access, working with other professionals. And, one of the big things is the level of our education, in my mind, is abysmal. and it's in it's in medicine, it's in I'm sure in nursing training, with pharmacy training, that the training I think tends to lag well behind. I recently heard a story about what a fourth year pharmacy student was learning about the treatment for depression, and I was just gobsmacked, honestly, that they were told never use an antipsychotic, an atypical antipsychotic. We're not supposed to use that word anymore, by the way. So never use an atypical antipsychotic for the treatment of depression, which has been in guidelines for years. And we have Health Canada indicated treatments, the FDA indicated treatments. So why are fourth year pharmacy students in this day and age being taught information that is clearly false and has been for decades? I think that we have to start with how we're educating individuals and also empowering patients to be able to speak for themselves, to feel confident. But again, when you're really ill, when you have a serious mental illness, it's so difficult to advocate for yourself. And I think that this is why the stigma persists. We continue to give less service to those who need it most.
It seems like it's just overall a very vulnerable and difficult situation, because if people are suffering in ways that we can do something about, then ideally we should make sure that everyone has access to that appropriate care before we even offer MAiD as an option. And whether that's through interdisciplinary care, virtual care, or enhancing our education and training, those are all things that we can do to hopefully improve the system. And I think the unintended consequence here is that we don't want people to feel like they have an easier access to dying than they do to the resources they need to live a well life.
That's absolutely true. They will have better access to dying than they will having access to care, whether it's in their family practitioner's office because they don't have one, or God forbid, needing to see a psychiatrist. They will have better access to dying than they will to care. And in 25 years as a psychiatrist, and I know many physicians will say, I know a patient who had absolutely irremediable mental illness. I have never had a patient that I felt there was not something else we could do together, ever. So there are absolutely people who have irremediable suffering, and I do not want people to suffer. But in 25 years in practice, there is always something else we can do. And, I may not be able to remove every single symptom. People have been sick for a long time. They have neuroprogression, but they make the decision that my life is worth living, not me. And I want to make sure that I give them every opportunity. And of course, the system is a barrier too. We can't get medications covered. The new medications, they don't necessarily work better because we have 25 antidepressants, and all of them work. We know they've been had Health Canada and FDA approval, but they don't work in every brain. And the newer antidepressants actually are more tolerable, which means people are more likely to take them because they don't have the metabolic side effects, or the sedation, or the sexual dysfunction, or whatever it is that's driving people bananas when they take their medication. But we don't have access to those treatments for most people, and especially in British Columbia, but across the country, we have serious access issues related to medication. And so they make decisions to die when there's always a path ahead. There are always other options.
The worry here, I guess, is the fact that maybe patients at the peak point in their mental health condition, they might choose to seek MAiD, whereas with time and resources and support, they might be able to move away from that decision if they were given the opportunity to have that care. Another concern that is present with legalizing MAiD for mental health is that it might disproportionately affect more vulnerable populations. And we did briefly touch upon this in terms of access, but there's also a lot of socioeconomic factors such as housing instability, food insecurity, or unemployment. And I'm wondering if you could talk a little bit about how these circumstances could directly contribute not only to a person's suffering, but also influence their decisions regarding MAiD.
Oh, absolutely. You basically answered your own question by listing those things. What are the determinants of health? And this is a very hot topic now, Health Canada has weighed in, the WHO has weighed in, and one of the top determinants of health and well-being is income, your ability to work, And if you have a serious mental illness that makes it impossible for you to work, or you're working, you're not able to hold a job that gives you enough money to maintain your housing, that you're food insecure, all of that has an impact on your mental health in general. Social support is the greatest protector of our mental health. If you're lonely, then that's going to have a major impact. And if you're depressed and it's hard to get out the door to do anything, let alone get out of bed, how do you maintain that social connectedness? So this is, adding to my concern is the fact that these more vulnerable populations that are most isolated are at greater risk. Why bother? I can't get a doctor. I can't access treatment. I'm on a provincial formulary and none of the medications that my doctor wants to give me are covered. So I can choose to be on this crappy drug that causes me to gain 40, 50, 60 pounds. And then my sugars are out of whack, and on it goes. This is part of what led me to get burned out, honestly, as a psychiatrist, was the fact that I was working in a system that completely lacked compassion and was so short-sighted that any new treatment that really was an advancement in tolerability, I couldn't access. So running around in circles trying to get samples and be on different plans and beg for special authority for these treatments. Most patients that I saw did not have a work plan through their work, did not have third-party coverage, and the formulary was terrible. And then once they were admitted to hospital, the care that they experienced within an emergency department was horrifying. And so, this is part of, I think, what's burning out some of our colleagues, is the fact that we're working in such a broken system.
I really appreciate that you mentioned that the system is broken, and I think we shouldn't shy away from the fact that there are some faults and improvements are necessary as we move forward. And I really appreciate that you mentioned that one of the top determinants of health is income. I think people who have mental health conditions may sometimes be more vulnerable to socioeconomic determinants of health, and they may be more vulnerable to be a part of that demographic that is facing financial struggles. I wanted to talk a little bit about the benefits that MAiD would provide. And I think an obvious one here is individual autonomy, to end one's suffering, the right to die in a peaceful and dignified manner. And I was wondering if you could talk a little bit about how we can balance having this respect for individual autonomy while at the same time encouraging and providing ongoing mental health support.
So the last thing that I want to see, not just as a psychiatrist, as a human being, is for someone to be suffering. And so an opportunity to stop someone's suffering is always, top of mind. And also, I believe that, I am a navigator on the ship with my patients. They are their captains. They're in charge. And, I'm an educated navigator. I know that these waters are pretty rough and these ones are a little smoother. And so that's my job, is to try to give them the best guidance that is personalized for them. And because most mental health care occurs in a family practice, family doctors usually have very little time to be able to spend to make sure that their treatment choices are personalized. Psychiatric diagnoses are very complicated. There's a lot of crossover between disorders. Sometimes it's hard to tell, is this anxiety, is it depression, is it both? The misdiagnosis rate for bipolar is like 95%. It takes decades to get the right diagnosis sometimes. So people are suffering. And I want them to feel that they have autonomy in all of their decisions. All of my patients, this is critical for me. And also they have the right, like any other disorder. I believe psychiatric disorders are medical disorders and rooted in inflammation, in fact, and neuroprogressive. So these are medical disorders like any other. The problem is we don't offer people care. We offer the same old thing. I'll tell you, last week, Thursday, I did a QA on one of the reports that I'm working on, Rapid's reports, and this individual was 60, in her 60s. I want to depersonalize as much as possible any content. This is a Canadian who is in her 60s and had come in with a diagnosis of depression and had been on venlafaxine XR. Its brand name is Effexor XR for the audience. Venlafaxine XR, 37.5 milligrams for 7 years. That dose, which is a starting dose, and she had very, very severe depression and anxiety symptoms, and in fact had bipolar 1 disorder that had never been diagnosed. So for 7 years, she's been on a starting dose of venlafaxine. And in fact, all this time, and really probably since she popped out of the womb, but certainly in her teen years, started getting depressed, she has had a bipolar 1 disorder that was not diagnosed. So we do a poor job. Everyone in medicine does a poor job when it comes to diagnosing psychiatric disorders, and then we don't treat them. And so no wonder people make a choice to either die by suicide, or now that the government will pay to remove you from the wait list through MAiD without offering any appropriate access to care. And I just want to come back to something you said about the system being broken. You know, I, for a long time, was talking about a stressed system or overwhelmed system. Our system is broken. Our healthcare system is broken. And until we all, as clinicians, as physicians, bravely say that to government, speak out loud, because I think in my experience, we do not stand together as physicians, and we need to. Our system is broken. There is almost nowhere in Canada where there is not a horrifyingly long wait list to see a psychiatrist. So it is broken, and our answer to that is MAiD in psychiatry, and that, to me, it's disgusting. It's horrifying, and that's why I speak out about it.
Well, thank you so much for that, and very surprising to hear that the solution to all of these problems, the answer shouldn't be MAiD. It should be just one aspect of care that is offered, but not a substitute for treatment and care. And I do want to highlight that mental health disorders are just like any other physical disorder. And there is no doubt that psychiatric conditions can cause intolerable suffering just as other physical conditions. But like you mentioned, the problem is access. So one of the eligibility criteria that you mentioned earlier was that the mental health condition should be incurable or irremediable. The worry here is that MAiD for mental health could contribute to a perception that these mental health conditions are incurable. And I was wondering if you worry at all about MAiD undermining our efforts thus far in improving mental health treatment and support.
Absolutely. When we have such an educational gap, a continuing stigma around mental illness, and then to open this up to say that, you know, mental illnesses are irremediable, there is a very, very, very small percentage of individuals where you cannot find a path, and that their suffering is so great. And that means, you know, you've gone through ECT, you've used ketamine, you've tried all of these different options, even, you know, vagal nerve stimulation, all the different options available, and there's no path ahead. That is, well, in 25 years, I haven't had a patient that I said to them, I don't think there's anything else. But I can tell you that the number of patients that have come to me and said, my doctor said there was nothing else, and they actually had the wrong diagnosis. Or the number of people, and this is why I jumped on the personality disorder thing earlier, the number of people, mostly young women, who have been in a distressed state and gone to an emergency department, and within moments being given a diagnosis of a personality disorder, which, by the way, requires a longitudinal history with someone and not in the middle of a distressing situation. Every young woman who goes to an emergency department distressed seems to be then labeled as borderline personality. Yet, strangely, if you actually do a history and use up some objective measures, ends up that they have a bipolar disorder that we can treat and changes their life. We just do such a poor job of diagnosis and treatment, and the stigma overlaying that continues to be an issue. And imagine being in a vulnerable population, so a group that is chronic drug use, some populations that have historically been marginalized within the healthcare system. I'm thinking like of Indigenous people. This is even worse. They're drug seeking when they come, when they talk to you about maybe they might have ADHD. Well, ADHD and bipolar go together, and not everyone. Well, if everyone is addicted to a long-acting psychostimulant, then why can't I get my patients to actually take them? Why is it so hard if they're all addicted to them? It's a poor medicine. We do a poor job of teaching, and we continue to have stigma infused in all aspects of medicine. And then we say, but let's kill people because they don't have access to care anyway. Or the one thing I tried, which was a sucky drug that Diane hasn't prescribed in 20 years, but I tried that and it didn't work. So it's irremediable. This is my concern.
And you mentioned misdiagnoses and also marginalized populations. And I think with the more structurally marginalized populations like Indigenous people or people with disabilities or people who have substance use disorders, there might be a lot of mistrust in healthcare too. And surely being misdiagnosed won't help with that. And then this could lead down to a domino effect or downstream effect that can impact their decision with MAiD. Now, as we're approaching the end of our episode, I wanted to ask you, what do you think are some of the changes that we need to see in our healthcare system before we can effectively accommodate MAiD for mental health?
I think that every level of our healthcare system requires change. And, mental models that we have, medicine changes at a glacial pace because we're taught by more senior medical people, and it's done this way, and we do it this way, and that's the only way to do it. And we have to break those mental models. And I think I'm always a glass half full person. So when I'm in the middle of crisis, I'm always thinking, what's the win? How do we pull the win out of this situation? How do we find the path ahead? And I think that what's come out of COVID and the high levels of burnout that we see amongst our colleagues is an opportunity to act and change things at every level. We need more diversity in the individuals who come into training. We need to expand, obviously, access to training, and we have to improve the quality of training in psychiatry. It is abysmal, and we need to improve that. You can be a family practitioner and go through some programs in this country and have 1 month of psychiatry, which is horrifying when you consider that at least half of the people that you see, you will be dealing with psychiatric conditions. So I think starting there, I think continuing to work on stigma within the community, but I think the community is actually far further ahead than the medical world, to be honest with you. And then thinking about the way that we communicate with patients, expanding on virtual care, integrating new technologies. And, again, part of our glacial movement and blinders on is our fear of technology. We have to have technologies that are carefully vetted to ensure that their quality. But this is the only way we're going to be able to move ahead, is by making sure that we're using the technologies that are there, or developing stronger ones that are easy to access, don't put more weight on clinicians, and empowering patients every step of the way. Every time we have an opportunity to encourage patients and their supporters, getting collateral, talking to an individual within their whole ecosystem, whoever they love. I have patients who their whole family is their furry family of their cat is their most important loved one. Honestly, then, bring your cat to your virtual meetings. However, we can support an individual, and recognizing that social prescribing is an important part of what we do in psychiatry. Do you have a place to live? Do you have access to services? And, if I've got your medication sorted out, or we're working on that, but also, are you lonely? Are you isolated? Are you going to seniors' homes? So giving people a more educating around a full circle of care, I think, is really important as well.
Those are all extremely important points. And I like how you talk about having a holistic approach to care. The reform is coming up in a few months in March, but we can only hope that we continue to make these improvements in our healthcare system and implement these changes. Now, as we approach the end of our discussion, I was wondering if you have any final thoughts or recommendations for our listeners, especially medical students who may be entering fields where they will encounter discussions around MAiD and equity in healthcare.
Just jumping on something you said, which is we have to hope that things are going to work out, or I know I'm paraphrasing. We don't need to hope. What if I have one thing to say to my new medical colleagues who are coming up to becoming my colleagues as physicians, you got to be brave here. We need to be brave. We need to stand together. We need to stand up for our patients, especially those who are in more vulnerable populations. I've witnessed again and again where I've written op-eds and I've gone and I've spoken out and said, we need to stand together, and people will not stand together. This we must do. If we are the experts in medical care, in mental health care, and so if we don't stand up, who will? We must stand together. And so if I have one ask of all of you, don't hope. I always hope, but don't make hope the primary aspect of your look ahead. Just be brave, be courageous, stand up for what you believe in. Make sure you have the facts. Don't turn to Dr. Google to make your determinations. Make sure you've got solid facts behind you, verifiable facts. Read the data, for heaven's sakes, and then stand up. I don't think I answered your question, but that's what I would like to ask anyway.
No, you definitely did. I think as medical students who are new to this whole system, sometimes it can be a little intimidating, but I think you're absolutely right to kind of stand together and take action in any way that you can at any level that you can. And I think that's a very good takeaway. So thank you so much for that. I also want to thank you for coming on and delving onto this very current and recent and crucial topic and issue. It's been wonderful chatting with you and learning from you and hearing your perspective around MAiD for mental health. So thank you so much for that. And also thank you everyone for listening, and tune in for more episodes of Just Medicine in the near future.